So I know that I'm speaking for both Barb and myself when I say that we're really excited to be here. Preventing and detecting gynecologic cancers is a topic that is very near and dear to our hearts. And we're excited to share our knowledge with you and answer any questions that you may have. Neither of us have any financial disclosures pertaining to this talk or at all. We wanted to start with a couple of definitions of key terms that we're going to be using throughout this talk. And so one of them is screening and prevention. What are they and how are they different from one another? So screening is really looking for cancer before a person has any symptoms. So it's any tests that are looking for cancer. And the goal really is to detect cancer at an early stage or even at its precursor or pre-cancer stage when it is vastly easier to treat. Prevention, on the other hand, is any action that is taken to lower the chance of someone getting cancer in the first place. So we'll talk about both screening and prevention methods for our three top gynecologic cancers as we move forward. Let's start with cervical cancer. So what is cervical cancer? Cervical cancer refers to cancer that starts in the cervix. The cervix is the organ that connects the body of the uterus where a fetus grows to the vagina or the birth canal. This is the portion that dilates during labor, allowing for vaginal delivery. Cancers of the uterine cervix, the vast majority are caused by a virus, and that's the human papillomavirus or HPV. HPV is responsible for about 99.7% of cervical cancer, so essentially all of them. What's important to know about HPV is that it's actually more than just one virus. There's many types or strains of HPV. There's over 200 known strains. Many cause skin warts, but some of them, about 40 or so, invade specifically the genital mucosa or the mucosal surfaces in general, which are the moist membranes that cover many organs, including organs that connect to the outside. So the mouth, the throat, the vagina, the cervix, the anus, the penis. And these genital or mucosal HPVs are divided into high risk and low risk strains. The low risk strains cause genital warts, and the high risk strains or types are responsible for many cancers beyond just cervix cancer. So cancers of the throat, of the mouth, of the penis, of the anus, of the vagina, of the vulva, and then of course of the cervix. So how does cervical cancer develop? Well, first of all, someone needs to be exposed to the HPV virus. And this does occur through sexual contact. It can be sexual contact of any sort, vaginal, anal, oral intercourse, even to some extent, genital hand intercourse, so this is less likely. But what's important to know about it is that this is a very, very common type of exposure. So 75 to 80% of adults who have ever been sexually active by the age of 50 are exposed to HPV. And the vast majority of infections are cleared by the body, okay? And how does this progress? So someone has a normal cervix, gets exposed to HPV, and a transient infection results in the cervix. 85% of the time or more, this is cleared by the immune system over the course of 6 months to up to 2 years, resulting in resolution of the abnormality and return to a normal cervix. But in a minority of the cases, this infection can progress into a persistent infection, which generates first a precancer, and over time, if this precancer is left untreated, it can result in cancer. We can detect this through various tests that we do on the cervix as either a normal cervix, low-grade lesions of the cervix, which are a sign of infection, high-grade lesions, which are a sign of precancer, and ultimately invasive lesions, which is what defines cancer. The good news is that this happens over a very long time period. So on average, 10 to 15 years, but as many as 30 years. And this gives us a great chance to detect and prevent cancer early. And that's what we'll talk about next. Okay, so who gets cervical cancer? Anyone with a cervix can get cervical cancer. There's going to be about 14,000 new invasive cervical cancers diagnosed in the US in 2022 based on the estimates, with about 4,000 of those cases unfortunately resulting in death. Most frequently, cervical cancer is diagnosed between the ages of 35 and 55. Rarely is it diagnosed before the age of 20. And it does occur in about 20% of cases do occur in people who are over the age of 65. There are several established risk factors for cervical cancer. Of course, a sexual history is a prerequisite because it is caused most of the time by HPV. Smoking is a huge risk factor for cervical cancer and one of the most readily preventable risk factors. That doubles a person's chances of getting cervical cancer if one is a smoker. And also having a weakened immune system. This can occur in HIV, in autoimmune diseases for which someone takes immunosuppressive medications, or after an organ transplant that also requires taking immunosuppressive medications. And this just makes it the body less readily capable of fighting this virus. The good news here as well is that looking at the US over the past 40 years or so, since 1975, we see a steady decrease in the incidence of cervical cancer. And this is directly attributable to prevention and screening. And that's why this is so important for a cancer like cervical cancer. And I should say also here, when I talk about risk factors, and we'll talk about risk factors for each of these cancers, having a risk factor does not mean you're going to get the cancer. And not having the risk factor doesn't mean you won't get the cancer. It's just all about the probability and the odds of getting a disease. So how can cervical cancer be prevented? So we have a vaccine for HPV. It is called Gardasil 9. It has been available in the US. Well, a form of Gardasil has been available since 2006. Most recently in 2017, we have Gardasil 9. This is the only one that's available in the United States. And it covers 9 different types of HPV. 2 types that cause common warts and 7 types that cause cervical cancer. And these are the most common types, including HPV 16 and 18, which again are responsible for 70% of cervical cancers. It is available for all genders, and it is recommended before someone starts being sexually active. So usually given between the ages of 11 and 12 in the United States. However, if someone does not receive the vaccine, catch-up vaccination is recommended up until the ages of 26, and it is approved by the FDA up until the age of 45, and may be a good idea for certain individuals with risk factors. 2 doses are given if it's given before the age of 15, and 3 doses are given if it's given after the age of 15. And that's just because our immune system is a little bit stronger at mounting a response if the vaccine is given before the age of 15. It is incredibly safe. We have mounts and mounts of evidence that it is a safe vaccine, and it is incredibly effective, 97 to 100% effective at preventing disease caused by the covered strains. So again, not all strains are covered, but the most important strains are covered. And to show you that HPV vaccination helps, at least at a population level, I want to show you some data for countries where vaccination rates are very high. So one of these countries is Australia. Australia has a program that was implemented in 2007, where first it was females, then it was extended to all genders, were vaccinated at schools and in catch-up vaccination programs at clinics, starting at the age of 11 and up until the age of 26. This program got started in 2007, and it has been incredibly successful, with 85% of females and 75% of males being vaccinated with the full course of the vaccine. And you can see in this younger cohorts, less than age 20 in blue, and between the ages of 20 and 24 in red, so this is the vaccinated cohorts, the risk of having, or the rates of having cervical cancer precursors has gone down dramatically as a result of vaccination. Not so in the cohorts that were not vaccinated, where the levels have remained about constant. So these are early signs that a vaccine can be really effective at a population level. Now, this relates to cervical cancer precursors because, as we've seen, it takes 10 to 15 years on average to develop cervical cancer. So we need more time to see how this is going to translate into prevention of cervical cancer itself. And then finally, this is a study that came out recently out of England, where vaccination rates are also very high. And I wanted to put it here because I really want to emphasize that getting the vaccine early really provides the best protection. So you can see here for cervical cancer on the left, and for a cervical cancer precursor called CIN3 on the right, that receiving the vaccine between the ages of 12 and 13 reduces someone's risk of getting cervical cancer by 87%, and even higher, about 95% of getting cervical cancer precursors. At the ages of 14 to 16, at the ages of 16 and 18, there is still some protection, but the degree of protection goes down. And this is presumably due to the fact that more individuals are going to be sexually active starting at these ages, and possibly because the immune system is so much stronger at mounting a response when it is given earlier. So for those in the audience who have children, I really highly recommend getting them vaccinated between the ages of 11 and 12. So how do we screen for cervical cancer? HPV vaccination is great, but it does not prevent all cancers. And whether someone has received the vaccine or not, we still very much recommend regular screening for cervical cancer. This is done in one of two ways, through the traditional pap smear. This is basically looking at cells that are in the cervix, okay? And HPV testing, which is looking at the virus itself, or co-testing, which looks at both. So this is usually done at a clinician's office. Patients are placed in the lithotomy or gynecologic position. A speculum is inserted into the vagina, and a brush is used to gently scrape away some surface cells of the cervix and then send them for analysis. Sometimes a couple of different brushes are used. They're ultimately collected into usually a liquid and sent for evaluation. We do have guidelines for the general population as to when screening should occur. It is not recommended before the age of 21. It is recommended started at the age of 21 with cytology, with the pap test every 3 years, or beginning at the age of 25, can also do HPV only testing every 3 to 5 years. Between the ages of 30 and 65, cytology can be continued every 3 years, or HPV alone testing can be done every 3 to 5 years, or co-testing can be done every 5 years. There's multiple options that are available to clinicians. And at the age of 65, if somebody has had adequate prior screening throughout their life, most of the time testing stops. I do want to point out some special circumstances. We mentioned that immunosuppressed individuals have a higher rate of getting cervical cancer because they're not able to fight the HPV infection as readily. And so more frequent screening is recommended for these individuals, usually every 1 year to start. And if all those tests are normal, it can gradually be spaced out to every 3 years, but not more than that. After a total hysterectomy, which refers to removal of both the uterus and the cervix, it is not necessary to continue screening unless someone has had a pre-invasive cervical cancer or cervical cancer in the past 20 to 25 years. And finally, taking a closer look at individuals older than 65, though most of those individuals can stop screening, there are times where a physician or a provider may make the decision to continue screening for longer in cases where prior screening has not been adequate, or a person has ongoing risk factors, and their life expectancy is at least 10 years, because we know that cervical cancer takes a long time to develop. And finally, there is an alternative screening method that I want you to be aware of for either individuals who don't have ready access to a clinic or who may find pelvic exams very disturbing for whatever reason. There is the option of self-collected vaginal samples that can be used for HPV testing. So these have been studied and are highly acceptable to patients. It's kind of like just a Q-tip that one inserts into the vagina. They're similarly accurate as a clinician doing an HPV-only test. Though I will say they can lead to greater rates, higher rates of follow-up procedures if an abnormality is determined, because if an abnormality is found, then co-testing will be needed and possibly more tests. But it is a great option for people who may not be comfortable or may find pelvic exams very difficult. And it's something that you can talk to your provider about. All right, so I'm going to switch gears real quickly to endometrial cancer. So endometrial cancer is a cancer that starts in the uterus, which is right above the cervix. This is the part where a fetus grows. And the uterus is divided into two components, the myometrium, which is the muscle layer, and the endometrium, which is the inner lining. And that's the part that sheds every month during periods. Cancers of the endometrium start in this lining. Okay. All right. Who gets endometrial cancer? Again, any person who has a uterus can get endometrial cancer. And in fact, it is the most common gynecologic cancer, with about a 3% lifetime risk of acquiring this cancer. It is the 9th most commonly diagnosed cancer in the US adults, 8th most common if you exclude prostate cancer, and it will affect about 66,000 people in the United States in 2022. The average age of diagnosis is 60, so usually after periods have ceased, after someone has gone into menopause. And there are many established risk factors. The most important risk factors really have to do with two hormones, estrogen and progesterone. So I wanted to spend just a little time here explaining the role of these two hormones on the endometrium. So the hormone estrogen and progesterone are hormones that are produced by the ovary. And estrogen makes the endometrium grow, and progesterone stabilizes the endometrium. And so they're kind of the yin and yang of hormones of the uterus. Any excess of estrogen in the absence or in the relative absence of progesterone can cause the endometrium to grow, ultimately in an uncontrolled fashion, which over time can cause cancer. And there's several conditions that can lead to extra estrogen in the body. One of them is being overweight, because we know that fat cells can produce estrogen, eating high-fat diets, never giving birth, or beginning menstruation or periods at an early age, or reaching menopause or period cessation at an older age, just because that extends the reproductive years, the number of years during which the body is exposed to estrogen. And during pregnancy, we're exposed mostly to progesterone, so it's actually protective. Having a syndrome called polycystic ovary syndrome. This is a condition by which the ovaries generate cysts every month, but don't generate or release an egg, which is necessary to transition from estrogen production to progesterone production. So these individuals may have a relative excess of estrogen. And finally, taking exogenous estrogens through, for example, hormone replacement therapy, when that hormone replacement therapy doesn't also include a progesterone. Another risk factor is taking tamoxifen. This is a medication that is given to many patients who have breast cancer, and it basically functions like estrogen at the level of the endometrium. And finally, there's a number of inherited mutations in certain genes that can predispose to a person's risk of having many cancers, one of which is endometrial cancer. The most common syndromes that we think about for endometrial cancer are called Lynch syndrome and Cowden syndrome. And Dr. Norquist will talk a lot about genetics when we talk about ovarian cancer as well, in ways that are analogous to endometrial cancer. So how can endometrial cancer be prevented? Well, in the general population, it's really all about risk factor reduction. Weight loss, healthy diet, physical activity, these are just good ideas in general and can decrease your risk of having endometrial cancer. And the other thing is avoiding that excess estrogen. So for example, if you're thinking of going to hormone replacement therapy, I 100% encourage that. But if you have a uterus, you should make sure that you're taking both estrogen and progesterone. If you know you have polycystic ovary syndrome, or you suspect you do, for example, because you're not getting your period every month, that might be an indication to go on some sort of hormonal therapy to restore that balance between estrogen and progesterone. And finally, I just wanted you all to know that hormonal contraceptives, so birth control pills, the Mirena IUD, all have been shown to reduce the risk of endometrial cancer, and by quite a bit, by 50% or so, especially if taken for at least 5 years. Now, we do not recommend you going on hormonal contraceptives for the purpose of decreasing your risk of endometrial cancer. But if you're looking for effective contraception, these options might be a good idea that also reduce your risk of endometrial cancer. For individuals with a genetic predisposition, so such as Lynch syndrome or Cowden syndrome, as we mentioned, we do offer a hysterectomy to remove the uterus. And this can be done at any time after completion of childbearing, if that is something that is desired. And finally, how do we screen for endometrial cancer? So for the general population, symptom awareness is really the key. Endometrial cancer tends to present very early with one cardinal symptom, and that symptom is abnormal uterine bleeding. Abnormal uterine bleeding is defined as bleeding that is menstrual but unusually heavy, bleeding between periods, bleeding after sex, or bleeding after menopause. Having abnormal uterine bleeding does not mean you have endometrial cancer, but it could be a sign of it. And so it should be further evaluated. So if you notice that, please speak to your provider to undergo the necessary workup to see whether it could be endometrial cancer. And then in general, even if you're not having abnormal uterine bleeding, regular visits to your gynecologist or to a primary care provider are important. They should take a careful history, including a bleeding history, and do a pelvic exam as well. And this is really just the basis of generalized screening for endometrial cancer, but there's no particular screening like a pap smear for detection of endometrial cancer. Finally, for patients with genetic predispositions to endometrial cancer, again, our Lynch syndrome patients, Cowder syndrome patients, we do offer a combination of pelvic ultrasounds and endometrial biopsies done every 6 to 12 months with the goal of detecting endometrial cancer early. So a pelvic ultrasound is done by a radiologist or sometimes is done at the gynecologist's office. And a transducer is placed into the vagina, which allows us to visualize the uterus, and in particular, the endometrium, which is the inner lining, and we can measure the thickness. And an increased thickness correlates with endometrial cancer. This can also be followed up with a biopsy. These are done, they can be done in the office. They're similar to pap smears, but a little bit deeper. So instead of taking cells from the outside of the cervix, a pipelle, a little device is put into the uterus, and cells from the actual uterine lining are scraped and sent for analysis. So that was my part. I'm going to let Dr. Norquist take it away with ovarian cancer.
Thank you so much, Dr. Jorge. That was really a great overview. I'm going to switch gears just a little bit to talking about ovarian cancer. So next slide. And thank you, Sol, for running my slides. So I'll kind of start with the same format Dr. Jorge was using. So I just wanted to spend a few minutes talking about what ovarian cancer is. We often use this term to kind of lump together 3 different cancers. So cancers of the ovary, the fallopian tube, and the peritoneum. And these cancers sort of look the same under the microscope. They behave very similarly, and we treat them very similarly. And there are some theories that perhaps all of these are fallopian tube cancers that just spread to these other areas. But for shorthand purposes, we tend to just call all of this ovarian cancer. The kind of basic stats, this is typically a disease of postmenopausal patients. So after periods have stopped with an average age of around 62. That average age can change if you are at a genetic predisposition for ovarian cancer, namely with an inherited mutation in the BRCA1 gene. And I will talk about that a few slides from now, but that syndrome, their risk of ovarian cancer is significantly younger, and the average age is about a decade younger, about 52 rather than 62. Most ovarian cancers are diagnosed at an advanced stage. And this is predominantly due to the biology of these cancers. They tend to start microscopically, either in the fallopian tube or the surface of the ovary, and they can spread very early in their course. So, and the symptoms at the start can often be somewhat vague and difficult to define. And all of these factors can lead to the majority of these cancers being diagnosed at stage 3 or 4. The most common treatment, kind of depending on the cell type, is usually a surgery to remove as much of the cancer as possible, as well as pretty extensive chemotherapy. And unfortunately, recurrences are very common. We are doing a lot better with novel therapies, and there's a lot of reason to be very hopeful in terms of the care of ovarian cancer. But unfortunately, most people do experience recurrence of their cancer. And at this time, most patients who develop ovarian cancer will eventually die from their cancer. And the average life expectancy is about 5 years. So this is mainly just to set the tone on why prevention of this cancer is so important. Okay, next slide. So wanted to say some of the risk factors for ovarian cancer, and a lot of these things are not really things you can modify or things that you would want to modify. I'm just mentioning them for the sake of the knowledge. So being at an older age, not having had a pregnancy or an older age at first pregnancy, and then inherited risk, which I will spend some more time on. And about 20% of patients with ovarian cancer, if you test their genes, you will find an inherited mutation that likely was the cause of that cancer, which is one of the highest rates of any of our solid tumors. So genetics plays a really big role in ovarian cancer risk. Things that are protective are essentially things that keep you from ovulating. So hormonal birth control pills, which is that picture there, pregnancy, and then removal of the fallopian tubes or tubal ligation. It's also something that decreases the risk of ovarian cancer. All right, next. And then what are the most common symptoms of ovarian cancer? And kind of anyone reading these can see how these are things that can happen to all of us at any given time. But the difference in these symptoms when they kind of just come and go versus when they're related to ovarian cancer is when these symptoms are related to ovarian cancer, they tend to get worse over time and they persist. They don't, you can't really link them in time to a certain food you ate or a menstrual cycle or something. These are persistent and progressive symptoms. So bloating, getting full quickly, which is sometimes called early satiety, abdominal or pelvic pain, and then also urinary frequency that you can't attribute to an infection. All right, next. And then I want to spend some time talking about the identification of inherited risk, because this is a really wonderful opportunity for ovarian cancer prevention. And I am kind of one of the medical directors of the SCCA's Breast and Ovarian Cancer Prevention Program, where we see patients who are at increased risk of inherited ovarian cancer. So that's really my perspective in talking to you about this. So again, around 20% of ovarian cancers are due to inherited genetic mutations that you inherit from a mother or a father. BRCA1 and BRCA2 are kind of the best known genes involved in this, and maybe things that you all have heard of. Lynch syndrome, which Dr. Jorge mentioned. These are caused by mutations in 4 different genes that also predispose to colon cancer and endometrial cancer, as well as ovarian cancer, and then some other things as well. And then in the last several years, they've also discovered several other genes implicated in ovarian cancer risk, RAD51C, RAD51D, BRIP1, PALP2. I don't expect you to remember all of these, but genetic testing has really changed over the last several years to, instead of just looking for BRCA1 and 2, we can now look at multiple genes at once. And so we're identifying more and more families that are impacted by inherited mutations in these kind of less common genes as well. All right, next. These are some statistics on the risk of breast and ovarian cancer in patients with BRCA1 and 2 mutations. Again, these are kind of the most common genetic syndromes that are linked to ovarian cancer. And if you look at the graph on the left, that's the incidence of breast cancer by age for BRCA1 and BRCA2 carriers. And you can see that there are very high risks of breast cancer, around 75% or so for each gene. The graph on the right are the risks of ovarian cancer. For BRCA1 carriers, that risk is around 44% by the age of 80. And for BRCA2 carriers, it's about 17% by the age of 80. And these numbers are really pretty staggeringly high compared to the risk in the general population, where the risk is only about 1.5 to 1.8% in the general population. So just quite a bit more common in patients with these inherited mutations. And I'm not sure if you can see this, but the BRCA1 line, which is the blue line on the ovarian cancer risk, you can see that that risk starts to go up at an earlier age than the risk for the BRCA2 carriers. And again, that's because the BRCA1 carriers really do have a risk for the early onset ovarian cancers. And these data kind of lead to the guidelines for prevention. Okay, next. So how do you find out if you are at risk? One of the most important steps can be to consider your family history of cancer. The cancers in the family that most tend to cluster around genes that also cause ovarian cancer risk are ovarian cancers, breast cancers, pancreatic cancer, endometrial cancer, and prostate cancer. And breast and prostate cancer are pretty common. So odds are many of us have family members with these cancers. And so it's important to try to figure out, who they are and how they are related to you. Visiting a genetic counselor can be an incredibly helpful step in determining if you are at risk or if you qualify for genetic testing. They can go carefully through your family history and let you know if you meet the criteria. The criteria are always changing because initially they were just based on who had the highest possible risk of having an inherited mutation. And then over time, as testing has gotten easier to access and less expensive, those rules have loosened a bit. And so it's a lot easier to qualify for genetic testing now. And there are several options that are much lower cost than they used to be. You can inherit these genetic predispositions from either your mother or your father. It's just the type of cancers you would normally see, like breast or ovarian cancer, can tend to be masked by kind of inheritance through the paternal side of the family. And so sometimes if there are not a lot of people in the family with breasts and ovaries, you are not necessarily going to see these cancers, but the inherited risk can still be there. This is a drawing of a pedigree with an aunt with, say, ovarian cancer. And then if you were the child here, you would still qualify for genetic testing, even though your father was unaffected because of the risk from the aunt. So the paternal inheritance can certainly mask things. And then they can talk about pros and cons of genetic testing, which can then be done with either a blood or a saliva test. And the saliva tests are kind of the most common route at this point. All right, next. So if you find out that you're at increased risk, what can you do about it? And it turns out there's actually a lot of things that you can do. First, knowledge really is power. I know that's a cliche, but understanding what the risks are, the timing of those risks, and having a team that can help you make a prevention plan can be incredibly helpful. I mentioned earlier that birth control pills can substantially reduce your risk of ovarian cancer. There are some patients with inherited risk who choose to take them strictly for that purpose. And taking birth control pills for 5 years or more can reduce your risk of ovarian cancer about in half. That option is certainly not for everyone, but it is just something to be aware of. The gold standard for prevention of ovarian cancer is actually surgery. And I will get into that here in a moment. So next slide. So because ovarian cancer is such a serious cancer, and because the risks are so high compared to the general population, really the gold standard for prevention of ovarian cancer is to surgically remove the tubes and ovaries. For BRCA1 carriers, this is recommended between the ages of 35 to 40. And for BRCA2 carriers, it's a bit later, again, because the onset of cancers is at a later age, and those guidelines specify 40 to 45. There are also guidelines for some of the other genes that I mentioned, and I didn't include them here kind of for the sake of time, but happy to take questions about that if anyone has them. And for Lynch syndrome, in addition to the risk of endometrial cancer, there's also a risk of ovarian cancer. And so for those patients, they can also be offered risk reduction surgery. And the source for these guidelines is the National Comprehensive Cancer Network. All right, next. Okay, so I wanted to go through kind of some of the surgery definitions, and who knows why gynecologists used these very cumbersome names for these procedures, but I'll try to demystify that a little bit. So a BSO is a term you'll hear gynecologists use, and that's because we don't want to say bilateral salpingo-oophorectomy. The salpinx is the fallopian tube and the ovaries are the oophorectomy part. And so a BSO is removal of the fallopian tubes and the ovaries. And then that's sometimes also called a risk-reducing salpingo-oophorectomy or an RRSO. So those are kind of our lingo terms. Okay, next. And then a salpingectomy is just removal of the fallopian tubes alone. This can be a risk reduction option for patients who also want to be sterile, because once you've removed the fallopian tubes, you cannot have a spontaneous conception. And this can be kind of a halfway step for patients who want to do something to reduce their risk, but are not yet ready for oophorectomy. And I could probably give a whole talk about that, so I'm going to skim over that a bit. And then hysterectomy just refers to removal of the uterus. And I find these terms all get jumbled together, and it can be tough for patients to know like what surgeries they've had, or even for other doctors in different specialties to use the right words. So, all right, next. Okay. And then I thought I would break this up a bit by just telling a story about a patient that I saw in the prevention clinic. So I'm calling this a tale of two sisters. At the top of this pedigree, you can see a dad and a mom. The mom had a breast cancer at the age of 38. But at the time I saw this patient, that was, about 30 years ago. And at that time, nowadays that patient would have been recommended to have genetic testing. But at that time, genetic testing was not commercially available. So that did not happen. There are two twin sisters, both age 37, and they're actually identical twins. And so the twin with the blue dot gets diagnosed with a stage 3 ovarian cancer. She then undergoes genetic testing because of her personal history of ovarian cancer and her mom's history of breast cancer, and is then found to have a mutation in the BRCA1 gene, which is probably what explains her cancer and her mom's cancer. And then her sister, because they're identical twins, also has the same BRCA1 mutation. And so after a consultation, she decided to have her ovaries and fallopian tubes removed prophylactically for prevention, kind of as it's indicated by the guidelines. So we took her to the operating room and surgically removed the ovaries and fallopian tubes. And in one of her fallopian tubes, she actually had what we believe to be the precursor to fallopian tube cancer. She had kind of a pre-invasive lesion in the fallopian tube, which, if left undisturbed, would likely have caused the same outcome that impacted her sister. So I feel like this family really kind of shows the promise of understanding the genetic knowledge and being able to take action for prevention. All right, next. So I don't mean to sound like everyone should have their ovaries removed. As it turns out, your ovaries do a lot of really good things for you. And so, like many things in medicine and life, this is a calculated kind of risk-benefit analysis, and it changes based on age and what is happening in your life. Removing the ovaries prior to natural menopause can actually increase all-cause mortality, and this is mostly related to kind of accelerated cardiovascular disease, osteoporosis, and other conditions that can be worsened by premature surgical menopause. You can make many of these things better with hormone replacement therapy. And hormone replacement therapy is something that we routinely recommend to our patients who have their ovaries removed prior to menopause. The main contraindication to taking hormone replacement therapy is if that patient already has an estrogen receptor positive breast cancer. Being at risk of breast cancer does not mean that you can't take hormone replacement therapy. And so this can often get fairly confusing, and it's best to find a specialist to discuss this if there's any concerns. There are multiple factors to consider. Obviously, if people are not done with childbearing, then removing the tubes and ovaries will make that very difficult. Different genes have different ages of onset of cancer, and so there's no need to rush into surgery at 25 when the risk doesn't start until mid to late 30s or even the 40s. And so you can cause a lot of harm by doing these surgeries at too young of an age. And then sometimes we will also incorporate the family history into this decision-making. If a person has a number of relatives who had very early onset ovarian cancers, then that can sometimes influence the recommendation for the timing. All right, next. And then you may notice I haven't said that much about screening. And why isn't screening an intermediate step? And part of the problem is these cancers start very small. And this is just a picture of a slide from an early microscopic fallopian tube cancer. And this wasn't seen with the naked eye. This is just only under the microscope. And we don't have any tests that can detect this kind of lesion other than surgery. The modalities we have now are a transvaginal ultrasound, which Dr. Jorge described earlier. That's kind of our best look at the ovaries, but you still can't see a microscopic thing like this. And a blood test called a CA-125, which is often elevated in patients with ovarian cancer, but can also be normal with a tiny cancer and can be elevated by things that aren't cancer. And so it's been really challenging. And there's been a number of large clinical trials trying to see if doing these tests help people live longer if they get ovarian cancer, or if we can even detect it early. And so far, the results have been really disappointing. This is not to say screening for other cancers is not effective, because it's incredibly effective for other cancers. I'm really just saying that for ovarian cancer, it is has a lot of issues and does not replace the gold standard of surgery, which is really the life-saving intervention. Okay, next. And so should anyone get ovarian cancer screening? For patients at normal risk, the US Preventative Task Service has actually come forward to say that ovarian cancer screening in normal risk patients gets a grade of D, and evidence to exclude this from periodic healthcare. So it's sort of actually recommended not to do it. For patients who are at increased risk, the NCCN recommends ultrasound combined with serum CA-125, although of uncertain benefit, may be considered. So this is kind of something that can be done, but is not something to hang your hat on. All right, next. All right, so that was kind of the basic overview. And then we wanted to give you all some resources for where to go if you need help. The uwmedicine.org website actually kind of lists a lot of the available clinics and phone numbers, and oftentimes with options to book online. So a primary care provider can be like probably the best place to start for any of these things. If you're interested in the Seattle Cancer Care Alliance cancer prevention clinics, this website will lead you to a description of the various clinics, and then they have kind of one phone number to help triage patients into which clinic they should consider going to. UW and the SCCA both have genetics clinics, and there are the phone numbers to schedule there, and they're doing all of those visits by telehealth at this point. And then our UW Gynecologic clinic, which most of the time people get referred to, but we do have some patients who self-refer, and that is the phone number there. And then cancer.gov has some just general information about various cancers. And then for patients at inherited risk of cancer, the FORCE site is a pretty rich source of information. It stands for Facing Our Risk of Cancer Empowered, and has kind of medically curated information and support groups and things.